Hey everyone. So today we have come with an important topic to discuss, that is membranous glomerulonephritis, extremely high yield topic. So let's discuss the membranous glomerulonephritis, and please don't forget to jot down all the key facts that we are going to discuss, and that will be very important for your exam point of view. So what is membranous glomerulonephritis? It is a very common cause of nephrotic syndrome. So as you all know, nephrotic syndrome versus nephritic syndrome. Nephrotic syndrome here, the patient characteristically presents with proteinuria. There is a high grade proteinuria is seen. High grade proteinuria, the proteinuria is more than 3 gram percentage, that is there. And there is also a lipid abnormality. There is a hyperlipidemia that is commonly noted in this condition. And here this membranous glomerulonephritis is commonly seen in certain races and all, and having more racial predilection in some areas. It is more common, but as such, it used to be the commonest cause of nephrotic syndrome, but now it is superseded by focal segmental glomerulonephritis. So here it is idiopathic causes there, which is most common, and there are lots of secondary causes. So secondary causes are often commonly being asked. The drugs are one of the important causes. Penicillamine, the drug used to treat the Wilson's disease, the copper chelator, the captopril, gold, NSAIDs, malignant solid tumors like tumors of lung, certain lung tumors, malignant melanomas. Lupus is one of the important causes, and apart from that, various infections like hepatitis B, hepatitis C, syphilis, malaria, and some autoimmune conditions like thyroiditis may be associated. So here it is a chronic autoimmune disease with immune complex mediated association is clearly being noted. And here what you will get over here, there is a increased thickness of the glomerular capillary wall and the basement membrane. So increased thickness of the capillary wall and the basement membrane is seen. So there is a subepithelial immune complex deposit basically between the basement membrane and the podocyte, and it gives rise to a dome and spike appearance on, particularly when we do the silver staining with silver stains, when we do the basement membrane staining. So spike and depressions are being noted. That is called as a spike and dome appearance. Thinning of food processes is noted, and granular deposits of immunoglobulin and complement C3 complements are being noted over here. So these immunoglobulins, generally it is IgG immunoglobulin. So IgG and C3 complement are being seen over here in membranous nephropathy. Clinical feature of membranopathy. So here it is, as I told you, it is seen in certain races and certain areas like Caucasian adults. It is very common, and here it is. Many of these patients, especially the primary cases, the idiopathic cases, they have the antibodies against the phospholipase A2 receptor. So phospholipase A2 enzyme, which plays an important role in generating various inflammatory mediators. So there is an antibodies against receptor to phospholipase A2. And here there is nephrotic syndrome predilection and presentation in most of the cases, but some cases in the late terminal stages may also have some nephrotic syndrome like hematuria, mild hypertension may be seen. Proteinuria also may be seen later on. It may be initially selective, that later on it may be non-selective as well. And here the treatment that is given is immunosuppressants like cyclophosphamide and prednisone, and there may be poor response to corticosteroids in some cases, and course of the disease is quite variable, and here there may be disease progression to end stage renal disease, which may necessitate transplantation in many of the cases. And here you see the common thing that we discussed, the most important thing that we discussed. Let's have a quick recap of that. So membranous glomerulonephritis is a common cause of glomerulonephritis and presenting with nephrotic syndrome. Various drugs, we discussed the various drugs like captopril, penicillamine, gold, NSAIDs. Various infections, malignancies, various collagen disorders are the common causes, and we discussed that there is a capillary wall and basement membrane thickening. We discussed that there is a hypercoagulability and renal vein thrombosis is a common complication, and it is managed commonly by immunosuppressants, and basically the steroids are also being tried up but there is a high predisposition to develop end-stage renal disease within 5 to 10 years and of course of the disease. So thank you for your patience. So hope you have learned and you jotted down all the key facts. Please like, share, and subscribe, and also get hooked to the channel for upcoming videos. And also please feel free to contact for any kind of coaching in pathology, whether it is a regular coaching or we have introduced 10 days crash course that covers all the vital aspects of pathology, which gears you up for your exams. So anybody lacking in the exam preparation, whether for USMLE, NEET PG, MBBS, etc., so you are most welcome to contact us individually. And also please feel free to download our app, that is Pathology Simplified, that contains lots of study materials and various other resources for your exam preparation. So thank you, and see you in the next video. Bye bye for now.